are very, very excited to have with us today Dr. Bonnie Henry, who many of you know and love as BC's Provincial Public Health Officer. And today, we're really just going to have an informal conversation about what's been going on with BC, what Dr. Henry has learned, and what she could tell us for second waves. So I'll hand it over to you, Dr. Henry. What explains the successes that you've had in dealing with COVID in British Columbia, do you think?
Well, I'll start off by saying it's a real pleasure to be able to talk to you all this afternoon, and I do want to acknowledge that I am talking to you from the traditional and unceded territories of the Lekwungen-speaking peoples here in Victoria. So that's the Esquimalt and the Songhees First Nation, and we're very grateful to be able to do what we do in this beautiful land. So yeah, that's the question. You know, we have, of course, a very good team here, and we had a lot of, I think we're all a product of our experiences. And so watching what was happening, having an early warning system, being acutely aware myself of what could happen, having been through SARS in Toronto, and I know there's some people on the line who were there with me for that. Those are all things that kind of underlie some of the reasons that we've ended up where we are. Of course, when we took some of the measures we took, we were, as everybody was, we were looking at the epidemic curve going up, and you never know how far or how fast it's going to go. So there was a lot of angst. But I do think some of it comes down to timing, absolutely, to knowing what measures to take, and a little bit of luck in some ways too. And you know, I often quote Louis Pasteur, who says luck favors the prepared mind, or Obi-Wan Kenobi, who says, in my experience, there's no such thing as luck, my young friend. Only highly favorable adjustments of multiple factors to incline events in one's favor. So either way, I think we were in a position where we had a very coordinated approach early on, and that made a huge difference. That allowed us to do things. We communicated very quickly, and I can't underestimate how important it was to have the political people, at least from my perspective, receptive to advice, and that took a bit of doing. I can say that you know, that the Minister of Health and our Premier, when I said these are the things we need to do, they supported it. So that's an incredibly important relationship that helped us too.
Great. So
I would be remiss without saying, you know, part of it was, and I talk about our coordination in BC, but having a central agency, the BC Centre for Disease Control, where we had brilliant people like Mel Crashdon, and we were able to get a lab test up and running really, really quickly in a very coordinated way. Those are the, you know, the practical pieces. That we had a strong public health system where I met regularly with our chief medical officers of health, and we put in place consistent coordinated approaches around the province and shared information. Those were really important too.
That's great that you mentioned that, and maybe I'll just ad-lib a little bit and ask you to expand. When you say you have a centralized system, I know in some other provinces, and we're already getting questions about other provinces, you know, public health is separate from health, and deployment of, let's say, healthcare workers occurs through private agencies and maybe isn't centralized. Can you maybe just explain a little bit how that works when you said centralized? Because I think that'll help people explain some of the success.
Yeah, you know, we have health authorities in British Columbia, so we have 5 geographical health authorities, and then we have a provincial health services authority, which has a number of the provincial agencies. So our BC Centre for Disease Control, which is our central public health agency, is part of our provincial health services authority. But it also has a direct reporting relationship to me in my office. And we are independent from the Ministry of Health. We're sort of in the Ministry of Health, but not of the Ministry of Health. So that allows us to have some freedom in terms of talking to the public about health issues. We also have our First Nations Health Authority, an incredibly important partner. and somebody who was the First Nations Health Authority was involved very early on with us. So instead of, I mean, Ontario, for example, where there's 36 health units, or 34, I think they're down to now, and where, you know, each hospital or hospital corporation has their own unions and their own ways of doing things, it makes it really, really complex. So when, and public health is part of the health authorities, which has its pluses and minuses. But when we said we need to have a coordinated provincial approach, there was only really 8 people I needed to talk to, or the deputy minister and I needed to talk to, not 15. And we could bring that together, and we had the ability to do that really quickly. You know, I can't say enough about our deputy minister, Stephen Brown, as well, who we had many, many very in-depth conversations about what this might mean, and he pulled the health system side of it together in incredible ways. So yeah, that's one of the things that has really, really helped us. So very early on, for example, we realized that private or public, our long-term care homes and our physicians in the community were not going to be able to get the PPE they needed because of the supply chains were all interrupted. Normally, you know, they get paid quite a lot of money to look after, to get those things. But so we included them in our provincial planning for our supply chain, our medications, PPE strain. You know, we put in place guidelines, and you know, we talked a little bit before this about PTSD, and I'm no stranger to that, having lived through the drama that we had, the trauma that we had with SARS in Toronto. And so very early on, I made sure that we had ethical frameworks that supported us in our decision making, in case we ended up with what we were seeing in northern Italy, for example, where we had scarce resources, and we as individuals felt that we would have to make those decisions, and those moral distress that causes. And so we have an ethical framework around PPE to make sure that we have a plan for how we will preserve and use it and make sure that people who need it have it. We have an ethical framework for duty to care that helps us understand, you know, what are the things we need to think about of coming to work every day. And we have an ethical framework around allocation of scarce resources, particularly ventilators, and a process that takes that decision making to a level that an individual physician doesn't have to be in that conflict.
Yeah, that's wonderful. It's amazing to hear you explain all this. Thank you. And now, of course, things are calming down across Canada, and hopefully people will literally have more breathing space. And we're still all a little bit nervous maybe about the fall, though, and what's going to happen, and second wave dynamics. And what lessons have you learned? The good stuff, but also the bad stuff, because we learn the best from our mistakes. Not that I'm suggesting you made any mistakes, but what lessons have you learned that, you know, you're keeping front of mind as we go into second wave dynamics? And maybe your comments could address particularly the transmission between long-term care institutions, because certainly out east we've been grappling with that a little bit more, and we've had many more outbreaks in long-term care.
Yeah, you know, there's a whole bunch of things, and we worry about the second wave and when it's going to come. And if we look back on this, we're in the position in public health anyway around decision making. You're never going to get it right, and the ethical underpinning is trying to do just enough to stop the transmission without having the negative impacts that some of the measures that we took. But in March, when we were all facing, you know, the epidemic curve going up and not knowing how far or how fast, you had to make a decision of doing too much or doing not enough. And we made the decision to do too much. And I think most of us did in this country, which meant we put in place a lot of measures all at once. We learned from Quebec that people traveling overseas were we're bringing back disease at a March break. We learned from what was going on around us. Particularly, we got flooded from Washington State. So we put in a whole bunch of measures in March, all of us did across the country, that reduced people's contact with each other, reduced people going into work. Um, the where we are now, if we're looking and going to the fall, we know this virus is probably going to be around at low levels. So our focus needs to be on minimizing it as much as we possibly can by finding that balance so that we don't go back to where we were in March. We know more now. We know how to manage it. We know where it shows up. We know who's most at risk. We know what we need to do to prevent it. So we need to manage um, outbreaks if they happen, and then we need to modify what we're doing if things change. We also now have good evidence, and some evidence, maybe not enough yet, but that distancing actually works and makes a difference. But it's also really hard for us as social creatures to maintain those distance. So as we're going into the fall, I don't know that it's inevitable we'll have a second wave, although I have said that, or at least I've been quoted as saying that. And I realize that part of that trauma is because as soon as we looked away just a teeny little bit with SARS-1 in Toronto, we missed a case, and we had a second wave in Toronto. And we just cannot have that now. I think we've damaged our psyches, our hearts, our communities so much. We need to find that way of balancing through through the fall in particular. And so I think what we need to think about is how do we have the lab capacity that allows us to differentiate influenza from COVID, because we know influenza is coming, absolutely. And then it makes it much more difficult to separate the wheat from the chaff again. And we get into that position when it's really hard to know. So we have to have expanded laboratory capacity everywhere, that we can have rapid turnover, that we can differentiate those in particular. We need to have very strong public health contact tracing and being able to find people quickly. And we need to go back to those isolation principles, but do it in a way that's much more titrated, much more titrated to the risk and where we know we can make the biggest difference. But going into the fall is kind of frightening. I mean, part of the things that we need to think about are we're all a traumatized community in healthcare, but also the people, elderly people. We've scared people. It's very hard to unscare them, and we need to do that slowly and carefully and thoughtfully. And then we need to find a place where we can maintain a level of our society and functioning and our health system through the next year.
Yeah, those are great pieces of advice, and a very, I would say, conservative and passionate, but hopefully effective outlook for the fall. So great things to be thinking about. I guess my last question, and then we'll open it up to people who are dying to ask you questions, is on this platform of scientists that we call CanCOVID. What do you think is the most important science to bring forward at this point? Are there decisions that you're grappling with where you think science or advances in science may help you significantly?
Absolutely. I mean, there's a whole lot of them. One is around the psychological and psychosocial impacts. And we've been doing some studies. We did a survey recently. 360,000 people in British Columbia answered about understanding the impacts. So that's going to help us, because we need to know which communities were most impacted, both from COVID, but also from the unintended negative consequences of the measures that we put in place. And we want to know if there's a spin-off positive consequences, so that we can enhance the positives and reduce the negatives as much as possible in the population. So that's one big thing. The one thing, I think, if there's one single thing that I would love to have an answer to, it would be immunity. How much immune globulin do you need? Do we have a good test for it? If you have it, does it protect you? So that whole, and I know we have an immunity task force, which is looking at those questions, but those are the big ones that can really help us support people in different environments in a way that will make a huge difference. I would love to have a point of care diagnostic test that is accurate, scientific, is sensitive and specific, and that we can do with a finger prick on a, or even better with a throat swab on site rather than an NP, because we're starting to get people refusing to be tested now because NPs are so challenging. I would like to know um, to how we can use the modeling to help us understand where we are in terms of the progression of the outbreak, so that we can take it, so we can understand when we're starting to get into danger zones, and that's some of the stuff we're looking at out here. I would like to know more about the effectiveness of cloth masks in the community. You know, the WHO just came out today with the recommendation to wear it in those short-term sessions, but you know, it would be nice to know. And I would love to take this opportunity to understand better how we can use masks in the healthcare setting as a source control mechanism. And we've had, as many people on this call know, a vaccinate or mask policy out here in British Columbia for a long time. And it was, you know, it was contentious, but if we can have a better understanding of us wearing a mask protecting our patients and putting a mask on the patient protecting us, those are really important concepts that can help us get through our respiratory season. I also will again say, I think part of the challenges we have had that have led to some of the transmission, but also the anxiety and fear that healthcare providers have had, is about this focus on the need for N95 respirators, and that's we need to move beyond that and focus on the system things that protect us, not just wearing a respirator.
That is an amazing list, and on behalf of all the scientists listening to you, I pledge that we will try to get you and all the other decision makers in our country the answers that you need to bring us into the fall. I'm going to turn now to the audience, et je vais dire aussi, s'il y a des francophones qui veulent poser des questions en français, me fera plaisir de les traduire, so I'm happy to translate any French questions that might be coming in. But here's one from Sybil. What can Ontario do to move towards what you're doing in BC? You know, we always like to give advice to people. What piece of advice would you give to Ontario very constructively, like that?
Oh, you know, and my heart goes out because I have many, many colleagues and friends in Ontario, and you know, especially my public health colleagues and friends, and it's been a very challenging time. And we have all faced a different pandemic across this country, so it's very challenging to compare. I will say that we need to do better across the country of sharing our experiences and getting that out from. You know, we have a special advisory committee, which is the Council of Chief Medical Officers of Health, and we meet we're meeting almost daily, but we're now down to 3 times a week. And we shared information. We had a long-term care outbreak very early on here, and we took a number of measures. We shared those, but we weren't able to effectively disseminate that information. We're also challenged in public health across the country, and I know in Ontario more so than we are here in BC, around how we can efficiently collect data. We have too many systems that don't talk to each other, and that leaves us playing catch up quite a lot. So those are some things if we could do between now and then. I just the need to have a coordinated approach that you can support each other in different parts of the province. And that's something that is a challenge for all of us, but is something that we're looking at focusing on for the fall, so that you know, if somebody gets sick in the north, I can have somebody that can fill in for them. We've had areas that have been overwhelmed with lots of cases in a very short period of time. So how do we balance that with each other? And I know Quebec has had some of those challenges as well in some areas where the people are sick and there's a lot of need.
Those are great pieces of advice. So now from Sonia Johnson, what more can be done to support people who use drugs who are still experiencing harms from the overdose crisis, as well as the impacts from COVID?
Yeah, and as everybody's aware, I'm sure, we have a dual emergency here in BC, and that is really the only other thing that's taking most of my time right now. Um, and we have used this occasion to do a couple of things. One is we have guidelines around provision of, that we were able to get through around provision of safe supply, so or safer supply, I would call it, pharmaceutical alternatives to street drugs is what we're technically calling it. So being able to provide people with hydromorphone or even a managed alcohol program, things like that. And we have managed to move people onto that. We know that there's two groups of people, at least here in British Columbia, who are more likely to be suffering the adverse effects of the overdose crises as well as the COVID, and part of it is because of supply chains for the drug dealers are interrupted. So the toxicity of our drug supply has gone up dramatically, and we've seen in April and March of this year, 112 and 117 people have died from illicit drug overdoses in British Columbia, which are the highest numbers we've seen in over a year. So it's partly the toxicity of the drug supply. It's also the fact that that some of this is happening in people who are underhoused and homeless, and because of the concern of risk, our shelter systems are at half space. So to put it all into context, so there's a couple of things. One is being able to provide inside safe housing for people, and we have a plan for doing that here in British Columbia. We're doing surveillance for people who use drugs who we're trying to manage the shelter system so that they can increase again. We're looking at how we can support our food banks, because we know food insecurity has increased, and that's been an issue that's contributed to people dying as well. So having a plan, and what we put together was a social sector homelessness task group that is addressing some of these issues. The other one, of course, that I feel strongly about is decriminalization of people who use drugs, because we know that that cycle and that stigma that's associated being criminally charged means that people hide their drug use. And we are seeing young men continually now in the higher numbers dying at home. So there's that second population. So there's the homeless people, people who are underhoused who use drugs, but then there's also people who are hiding it at home. And family members tell us that they didn't realize they had relapsed, or didn't know they were taking drugs, and it keeps people, that stigma keeps people from sharing and reaching out for help.
Yeah, some of those are wicked problems, as we call them. So the next two questions, I think, are really about ethics, one from Sybil and one from Nora, asking about if your ethical framework for PPE is publicly available. And it seems that in Ontario, they just published a draft triage document, and looking at decisions like people with disabilities and where do they stand in relation to accessing a ventilator. So can you talk a little bit about your access to your guidelines and maybe the approach there?
Yeah, they are all public, yes. So they're available on the BC CDC website, and on the, actually they might be available as well on my website or on the PHO Government of BC website. Just Google COVID ethics and it'll come up. And we do address issues around and the ethical principles that underlie ventilator allocation, for example, which is that every person's life is valued equally, and that we will not be making decisions based on somebody's disability or age. It'll be based on objective criteria around survivability within a short period of time. So we have gone through quite a lot of ethical review with a group of ethicists, with clinicians, and we've gone through both legal and our privacy and non-privacy, our Human Rights Commissioner's office as well. So we feel that the guidance we've come up with is strong.
Great answer. This is from Diane Finegood. How did you know that principles, calm, safe, kind, would likely be better than a rules-based approach?
So this is something that I have learned, and people have asked me this, and it comes from, we're all products of our own experiences. So it comes from learnings working in places like Pakistan and Afghanistan, the Ebola outbreak in Uganda, the SARS outbreak, understanding, 9/11 in the US, the events that I've been part of, and realizing that when we're in an event like this, that a viral illness that doesn't recognize any of our geopolitical, social, ethnic, racist attitudes or anything, um, that the only way that we're going to get through this is to do it together and to build that sense of common suffering, if you will. And that's, as a maritimer, we say that common suffering builds strong bonds. Um, but recognizing that we don't always know the other person's story, and that we can't make assumptions based on somebody's, what they look like, which is the early things. It was like, oh, that's those Chinese people putting us at risk, and we're, so our philosophy, and thankfully my government was happy with this too, and I was quite adamant about it, that we really needed to take it from a position of kindness and compassion and understanding. And I've said this before too, that we're all around the world in the same storm, but we are not all in the same boat. And we need to give people the tools to keep all of their boats afloat. Um, so we know from human nature that if we tell people what they need to do, if we give them the reason why we need them to do it, and that's why we're so adamant about being transparent and presenting the data to people. And we give people the means to do it, that most people will do what we ask them to. And that's borne out. And if we get into recriminations and fining and the sort of the way they approach that is authoritarian and punishment, then it doesn't stop. You can't put an end to it. So like I got criticized this week because I didn't send, I didn't say police should break up these demonstrations against anti-police violence. It's like, no. And they're like, well, people are being fined for sitting on park benches. And I said, no, they're not in this city, not in this province, because we didn't take that approach. We took the approach that, go outside, keep your distance, be respectful, do this for yourself, do this for your family, your community. And that's the approach we've been taking to the demonstrations. And, not everybody pays attention, of course, but most people do.
Well, we're big fans, and it's working. I have about 5 more questions in about 2 more minutes. Let's go through them, and you'll tell me when you want to stop.
Those who know me know I talk too much.
Oh, I don't think any of us are criticizing that at all. We're very grateful. So as social distancing is relaxed, what data will be the most useful for upcoming policy decisions?
Yeah, so a couple of things that I have obviously thought about this a lot. As physical distancing, as the things start opening up again and the restrictions are lifting, we need to maintain those physical distances. And that's another place we need some more evidence, but I think it's working. We've got a bit that 2 meters probably is a good thing, and it's better if it's outside than inside. So what we need to look at, what I'm focusing on is minimizing transmission, recognizing every unrelated case in our, so how many of the cases that we're identifying in our community are not linked. So unlinked cases, really, really important. Because if we start to see a lot of them in various places, that's what gets us into trouble again. So we want to be able to test enough and be very sensitive about anybody who has a symptom getting tested, so that we can tell if there's unlinked cases. And it's working now. It took us a while, but we're now finding, like, once we recognize where things are happening. So we recognize it was happening in long-term care. We recognize that it was happening in our correctional facilities. And don't get me started on that. and federal correctional facilities, and we recognized it was happening with temporary foreign workers. Once we recognize things, we can put things in place. Now, as we're lifting restrictions, we're seeing clusters in workplaces. But our last 4 clusters in workplaces were 2 people. So, now that we know, we're telling people you need to be really careful. And if you're going to work and you're not feeling well, go home and get a test. And we're finding people. So that's where we need to go. And we need to, me and public health needs to really monitor if we're starting to see community spread that we can't link. Those are signs that we need to start putting in more messages in around keeping our distance and stopping our contacts again.
Fabulous piece of advice. What are your top risks to long-term care facilities that don't have any cases yet?
Yeah, right now the biggest risk is we still, in all of our long-term care facilities, have not allowed family visitors and family caregivers. And the biggest risk is people are going to die before they have a chance to hug their family again. And, that's in the short term. And we have to find that balancing of letting families in a way that doesn't overwhelm staff, because we are very short-staffed as you are across the country, and doesn't introduce too many people into an environment that we know is still risky. But everybody wants to be with their one. So we're working very carefully on that right now to try and at least find ways to do it in a slow and measured way.
Yes, you probably know that Quebec started doing that about 3 weeks ago, and you're probably comparing notes. So it's interesting that people are moving at different paces. And do you have any recommendations for Quebec, and particularly Montreal, as the epicenter of the epidemic, other than what you said to Ontario, just throwing it out there?
It's the same thing. It's so hard. And once you get to that point where it's been spread, and now that we know that there's pre-symptomatic, and people may not recognize when they have mild symptoms, and once you get behind and you're playing catch up, it's very, very challenging.
And how do you envision the phase 3 vaccine trials rolling out across Canada, particularly with respect to the equity lens on geographic areas and populations? And maybe I'll just combine another question, what can northern remote facilities do to reduce the impact? So this idea of geography and at-risk populations for vaccine trials in Canada.
For vaccine trials would be, I hadn't really thought about it in terms of trials. I have thought about it in terms of immunizing, and the National Advisory Committee on Immunization is working on that now. Some people may know, how do we prioritize? Who do we prioritize, and why? In terms of vaccine trials, I hadn't thought about that, but we know that it's really highlighted the differential impact of an outbreak on different populations, and particularly racialized populations, people who are low socioeconomic status, often in large multi-family dwellings and crowded conditions. And some of that is reflected as well. And I do believe we have an obligation to differentially work with our First Nations and Indigenous peoples, the First Nations and Indigenous people in Canada, to provide them with all of the support that they need, because we know that they have historically been impacted far more than other Canadians by outbreaks and by pandemics. So there's a combination of things. So I think we should be offering to do trials with Indigenous communities. We should be offering to do it in populations that we know are more likely to be affected, and many of them are healthcare workers who come from other countries.
Great. And what's been your approach to balance the health benefits of some of the measures versus their economic impacts?
Yeah,
provinces have approached this. I say from Quebec, yes.
This has been our burden from the very beginning. My explanations to our political people were, you can't get health back, and you can't get it back if somebody dies. We can provide, we can do things to get the economy back. So very first and foremost, we need to take care of people who have COVID, but take care of our care system, our healthcare system, because if we see what happened in parts of China, we see what happened in northern Italy, if your healthcare system gets overwhelmed, it's not only people with COVID who die, it's people who can't access the care that they need other than COVID who die as well. So, and that is, it's been hard because we all, well, I take responsibility for this. Oh my God, I'm ruining the economy. But it's the virus that's ruining the economy. And what we can do is do everything we can to protect our systems that keep our health so that we're here to get the economy going when it's ready.
Well, you have a shout out from the audience that you are a great and wise systems thinker, Dr. Bonnie Henry, and those who are attending from BC are feeling particularly proud listening to you right now. Maybe I'll end with the last question and a shout out for our talk actually on Tuesday from Dominique Frigon, who's going to be talking about wastewater and how it might be used to detect virus in the community. And the question that I have for you is, does the Canadian Public Health Establishment, are they embracing this idea of wastewater testing? We know that it's being done in the Netherlands and Germany and Finland and some places in the EU, but how are we approaching this here in Canada? And again, if you want to know more, we do have someone speaking about it on Tuesday, 4 o'clock at our next talk, but go ahead.
Absolutely, and I showed out again to the BC CDC. I see Mohammed Morshed is on the call, and Natalie Christojecki. Absolutely, we are looking at wastewater and how can it help us. So I think there's a couple of ways that it can help us. One is sort of the on-off. Is it in our community? And we can do some surveillance, and I think that's something that's really promising for more remote and rural communities, where you can actually pick it up and it's either there or it's not there. I think what we're also looking at is in larger cities, does it help? Is there a sense of, a lot or a little, giving you an idea of how well you're doing or whether you're missing things? So we had a conversation about this just last week, and we in the health system, or the public health world, are actually quite excited about using it as it's not going to help us in the sort of day-to-day management in some cases, but it will help us in a general understanding of where we are and sort of situational awareness. And I think it has great promise for some of the more remote places where we could potentially determine if it's actually in a community or not. And I liken it to what we have seen with polio in parts of the world, where polio has been eradicated and then it's been found in the environment in Israel not that long ago, a year or so ago, where they found it in the environment and then a case popped up. And so they were able to judge a little bit about how much was in the community. So I think it has a lot of potential as an adjunct.
Well, there's so many more interesting questions, but I think you've been more than generous with your time. Everyone says thank you, and my bad for saying only people in BC are proud of you. It seems people in Yukon and everyone you know and across the country are very, very proud of you. So we may just have to invite you back in the fall to tell us how you managed not to have a second wave, or to explain to us how you contained it. So wonderful talk. Thank you very much.
Thank you.
We wish you the best.
I'm so proud of being Canadian, because one of the things we have done is, getting all the best and brightest minds together, and we're going to get through this together. Thank you.
Well, thank you, and I understand it's your first weekend off in 156 days, so go forth and conquer. Thank you very much, everybody.